Question 1. The nurse measures a patient's ECG strip and notes the following. Rate 88 beats per minute, regular rhythm. PR interval 0.22 seconds. QRS complex 0.08 seconds. What is the interpretation of this rhythm? A. Normal sinus rhythm. B. Sinus bradycardia. C. First degree AV block. D. Junctional rhythm. Answer. C. First degree AV block. Rationale. Normal sinus rhythm has a PR interval of 0.12 to 0.20 seconds. A PR interval greater than 0.20 seconds, 0.22 seconds in this case, with all other parameters normal, defines a first-degree AV block. The rate 88 is normal 60 to 100. Question 2. A patient's monitor shows an irregular rhythm with a ventricular rate of 145 beats per minute, a narrow QRS complex, and no discernible P waves. What rhythm should the nurse identify? A. Atrial flutter with 2:1 block. B. Supraventricular tachycardia, SVT. C. Atrial fibrillation with rapid ventricular response, RVR. D. Ventricular tachycardia, V-Tach. Answer. C. Atrial fibrillation with rapid ventricular response, RVR. Rationale. Atrial fibrillation is characterized by a chaotic or irregular rhythm and the absence of P waves. A rate over 100 beats per minute classifies it as RVR. Option A would be regular. B would be regular and likely faster. D would have wide QRS complexes. Question 3. On an ECG strip, the nurse observes a pattern where the PR interval lengthens with each beat until a QRS complex is dropped and the cycle repeats. What is this rhythm? A. Second degree AV block, type 2 to B. Second degree AV block, type 1 Wenckebach. C. Third degree AV block. D. Sinus arrhythmia. Answer. B. Second degree AV block, type 1 Wenckebach. Rationale. The hallmark of second-degree AV block, type 1 Wenckebach, is a characteristic pattern of a progressively lengthening PR interval until one atrial impulse is blocked and the ventricular beat is dropped. Question 4. A patient's rhythm changes abruptly to a regular rate of 210 beats per minute with narrow QRS complexes and no visible P waves. The patient is stable. What is the priority nursing intervention before calling the physician? A. Prepare for immediate defibrillation. B. Assess for the presence of a pulse. C. Instruct the patient to perform a vagal maneuver, for example, bear down. D. Administer a rapid IV push of adenosine. Answer. C. Instruct the patient to perform a vagal maneuver, for example, bear down. Rationale. This is likely a stable supraventricular tachycardia, SVT. For stable SVT, the initial nursing intervention is to attempt vagal maneuvers, for example modified Valsalva, to slow the heart rate by increasing vagal tone, before administering medications like adenosine, D, or notifying the physician. Question 5. Which rhythm is characterized by wide, bizarre QRS complexes occurring in a sequence of 3 or more beats at a rate greater than 100 beats per minute? A. Accelerated junctional rhythm. B. Ventricular fibrillation, V-Fib. C. Ventricular tachycardia, V-Tach. D. Atrial tachycardia. Answer. C. Ventricular tachycardia, V-Tach. Rationale. Ventricular tachycardia is defined as 3 or more PVCs in a row or run, with a rate typically over 100 beats per minute. The beats originate in the ventricles, resulting in wide and abnormal QRS complexes. Question 6. A patient with a heart rate of 32 beats per minute and signs of hypoperfusion, hypotension, dizziness is showing a third-degree AV block. What is the highest priority intervention? A. Prepare to administer IV lidocaine. B. Prepare for transcutaneous pacing, TCP. C. Administer IV fluid bolus. D. Administer oral beta blockers. Answer: B. Prepare for transcutaneous pacing, TCP. Rationale: third-degree AV block with hemodynamic instability is a cardiac emergency. The primary treatment to increase the heart rate and improve cardiac output is transcutaneous pacing, TCP. Lidocaine A is for V-Tach. Beta blockers, D, would slow the heart further. Question 7. The nurse identifies a brief pause in the rhythm where AP wave and QRS complex are completely absent, followed by the resumption of the original rhythm. This pause is most likely caused by A. Second-degree AV block, type 2. B. Asystole. C. Atrial fibrillation. D. Sinus arrest. Answer: D. Sinus arrest. Rationale: sinus arrest occurs when the SA node fails to fire for a period, causing an absence of a PQRST complex. The pause length is not a multiple of the RR interval, and the rhythm typically resumes spontaneously. Second-degree AV block involves dropped QRS complexes, but P waves continue. Question 8. When analyzing a patient's ECG, the nurse notes the absence of P waves, a slow heart rate of 45 beats per minute, and narrow QRS complexes. Where is the pacemaker site most likely located? A. Sinoatrial SA node. B. Atrioventricular AV junction. C. Ventricular Purkinje fibers. D. Atria. Answer: B. Atrioventricular AV junction. Rationale: this is a junctional rhythm, which occurs when the pacemaker site shifts to the AV junction, AV node, or bundle of His. The intrinsic rate is 40 to 60 beats per minute. P waves are either absent or inverted, and QRS complexes are narrow. Question 9. Which ECG characteristic is essential for diagnosing a second-degree AV block type 2? A. Progressively lengthening PR interval. B. Consistent PR interval for conducted beats, with sudden drop of QRS. C. Total AV dissociation with independent P and QRS activity. D. PR interval greater than 0.20 seconds with every beat conducted. Answer: B. Consistent PR interval for conducted beats, with sudden drop of QRS. Rationale: second-degree AV block type 2 is characterized by a fixed, normal PR interval for conducted beats, but with sudden, unexpected drops of a QRS complex, without prior PR lengthening. This block is typically below the AV node and carries a higher risk of progression to complete heart block. Question 10. The nurse finds a pulseless, unconscious patient whose monitor shows an irregular, chaotic, wavy line with no clear QRS complexes. What is the immediate intervention? A. Administer atropine 0.5 milligrams IV. B. Initiate CPR and prepare for defibrillation. C. Prepare for synchronized cardioversion. D. Start transcutaneous pacing, TCP. Answer: B. Initiate CPR and prepare for defibrillation. Rationale: this rhythm is ventricular fibrillation V-Fib, a lethal, non-perfusing rhythm. Immediate action is CPR and rapid defibrillation according to ACLS protocol. Cardioversion C is for rhythms with a pulse. Question 11. The nurse observes frequent runs of bigeminy PVCs. What electrolyte imbalance is the nurse most concerned about in relation to this dysrhythmia? A. Hypernatremia. B. Hypocalcemia. C. Hypokalemia. D. Hypermagnesemia. Answer: C. Hypokalemia. Rationale: hypokalemia, low potassium, is a major cause of increased myocardial irritability, which commonly presents as premature ventricular contractions, PVCs, and can lead to more dangerous ventricular dysrhythmias. Question 12. After defibrillating a patient who was in V-Fib, the monitor shows a wide, regular rhythm at a rate of 40 beats per minute with no visible P waves. What is this post-resuscitation rhythm? A. Sinus bradycardia. B. Accelerated junctional rhythm. C. Idioventricular rhythm. D. Sinus rhythm with first-degree block. Answer: C. Idioventricular rhythm. Rationale: an idioventricular rhythm is a ventricular escape rhythm with a very slow rate, 20 to 40 beats per minute, wide QRS complexes, and no P waves, as the beat originates in the ventricles. A rate of 40 would be at the high end of this range, or possibly an accelerated idioventricular rhythm, but idioventricular is the best fit. Question 13. A patient is in atrial fibrillation with a controlled rate of 85 beats per minute. What vital sign assessment is most important for the nurse to perform due to the rhythm's irregularity? A. Radial pulse for 15 seconds. B. Apical pulse for a full minute. C. Blood pressure every 4 hours. D. Respiratory rate. Answer: B. Apical pulse for a full minute. Rationale: because atrial fibrillation is irregularly irregular, the peripheral pulse radial may not accurately reflect all cardiac contractions due to pulse deficit. The most accurate heart rate for assessment requires counting the apical pulse for a full minute. Question 14. The nurse notes that a patient with a permanent pacemaker has pacing spikes that occur on time, but are not followed by a QRS complex. This malfunction is termed A. Failure to sense. B. Failure to capture. C. Oversensing. D. Undersensing. Answer: B. Failure to capture. Rationale: failure to capture means the pacemaker delivered an impulse, spike is present, but the heart muscle failed to respond, depolarize, meaning the expected P wave, atrial capture, or QRS complex, ventricular capture, is missing after the spike. Question 15. What is the primary significance of a prolonged QT interval on an ECG? A. Increased risk of atrial fibrillation. B. Increased risk of developing torsades de pointes, polymorphic V-Tach. C. Indication of a completed myocardial infarction. D. Sign of digitalis toxicity. Answer: B. Increased risk of developing torsades de pointes, polymorphic V-Tach. Rationale: a prolonged QT interval indicates delayed ventricular repolarization, which significantly increases the risk of developing a life-threatening, often drug-induced, ventricular dysrhythmia called torsades de pointes, a form of V-Tach. Question 16. A nurse is teaching a patient about their newly prescribed digoxin. The nurse emphasizes the need to immediately report which symptom, as it may indicate a life-threatening change in cardiac rhythm. A. Increased urination. B. Feeling of heart skipping a beat. C. Increased appetite. D. Mild headache. Answer: B. Feeling of heart skipping a beat. Rationale: digoxin toxicity can cause severe dysrhythmias, including PVCs, which the patient may perceive as a heart skipping a beat or palpitations. This is a crucial sign that requires immediate medical follow-up due to the narrow therapeutic window of digoxin. Question 17. The nurse observes a patient's rhythm changing from normal sinus rhythm to a rate of 115 beats per minute. There are no other changes in the strip. P waves, PR, QRS are normal. What is the priority focus for intervention? A. Initiate emergent defibrillation. B. Search for the underlying cause, for example pain, fever, anxiety. C. Prepare to administer amiodarone. D. Document as a stable finding. Answer: B. Search for the underlying cause, for example pain, fever, anxiety. Rationale: this is sinus tachycardia, which is rarely a primary problem, but usually a compensatory mechanism. The priority is to identify and treat the underlying cause, for example pain, hypoxia, fever, anxiety, hypovolemia, to resolve the tachycardia. Question 18. In an unstable patient experiencing ventricular tachycardia with a pulse, what is the most appropriate initial medical intervention the nurse should prepare for? A. Unsynchronized defibrillation. B. Synchronized cardioversion. C. IV push of adenosine. D. IV push of atropine. Answer: B. Synchronized cardioversion. Rationale: for unstable V-Tach with a pulse, the electricity must be delivered synchronized with the R wave to avoid inducing V-Fib. Therefore, synchronized cardioversion is the initial treatment. Defibrillation A is for pulseless rhythms, V-Fib, pulseless V-Tach. Question 19. A patient with a history of an old myocardial infarction, MI, has a consistently wide QRS complex, 0.16 seconds, but otherwise exhibits normal sinus rhythm, rate 78, P wave present. What is the most likely cause of the wide QRS complex? A. Second-degree AV block, type 2. B. Bundle branch block, BBB. C. Accelerated junctional rhythm. D. Atrial tachycardia. Answer: B. Bundle branch block, BBB. Rationale: a bundle branch block, BBB, is a common finding after an MI. It delays ventricular conduction, causing the QRS complex to be prolonged, wider than 0.12 seconds, even when the rhythm originates normally from the SA node and SR. Question 20. The nurse notes a rhythm strip with a ventricular rate of 55 beats per minute, regular rhythm, and an inverted P wave that follows the QRS complex. This rhythm is characteristic of a beat originating in the ASA node. B. Atria. C. AV junction low. D. Ventricles. Answer: C. AV junction low. Rationale: this is a junctional rhythm, rate 40 to 60 beats per minute. When the AV junction paces the heart, the P wave may be absent, inverted, or, as in this case, follow the QRS complex, indicating that the atria were depolarized in a retrograde fashion after the ventricles. Question 21. A patient's rhythm is regular, with a rate of 160 beats per minute. P waves are visible, but appear to be conducting 2:1, resulting in a ventricular rate of 80 beats per minute. The QRS is narrow. What is the most probable rhythm? A. Atrial flutter with variable block. B. Sinus tachycardia with aberrancy. C. Atrial tachycardia with 2:1 conduction. D. Junctional tachycardia. Answer: C. Atrial tachycardia with 2:1 conduction. Rationale: atrial tachycardia originates outside the SA node, with a regular ventricular rate of 80 and a presumed regular atrial rate of 160, 2:1 conduction. This fits at atrial flutter. A typically has a faster, sawtooth atrial rate, for example 250 to 350 beats per minute. Sinus tachycardia, B, would have a ventricular rate of 160, not 80. Question 22. A patient is post-cardiac arrest and receives a dopamine drip. The monitor shows a regular rhythm at 110 beats per minute with no P waves, and a QRS complex measuring 0.14 seconds. What rhythm is most likely present? A. Accelerated idioventricular rhythm, AIVR. B. Ventricular tachycardia, V-Tach. C. Accelerated junctional rhythm, AJR. D. Atrial fibrillation with RVR. Answer: A. Accelerated idioventricular rhythm, AIVR. Rationale: AIVR is a regular rhythm with a rate between 40 to 100 over 120 beats per minute, wide QRS complexes originating from the ventricles, and typically no P waves, AV dissociation. V-Tach B is usually greater than 100 beats per minute. AJR-C has a narrow QRS. The rate of 110 sits in the range, sometimes classified as AIVR or slow V-Tach. Question 23. The nurse observes a patient's monitor showing a run of PVCs where every third beat is a PVC, normal PVC. How should the nurse correctly document this pattern? A. Trigeminy. B. Quadrigeminy. C. R-on-T phenomenon. D. Couplet. Answer: A. Trigeminy. Rationale: trigeminy is a repeating pattern where every third beat is a premature beat, in this case a PVC. Bigeminy is every second beat, and quadrigeminy is every fourth beat. A couplet is two PVCs in a row. Question 24. A patient's ECG shows P waves and QRS complexes that are independent of each other. AV dissociation. The ventricular rate is 65 beats per minute. This rhythm is most likely an accelerated form of what type of block or rhythm? A. Third degree AV block. B. Junctional escape rhythm. C. Sinus bradycardia. D. Second degree AV block type 1. Answer: A. Third degree AV block. Rationale: AV dissociation is the classic hallmark of third degree complete AV block. However, the ventricular rate is 65 beats per minute, which is faster than the usual 30 to 50 beats per minute, suggesting a more active, accelerated, lower pacemaker site, likely in the bundle of his or ventricles, overriding the traditional slow escape rate. Question 25. A patient is in atrial fibrillation. The nurse notes several extremely slow ventricular responses, 15 to 20 beats per minute, followed by pauses. This is best described as an issue with which part of the conduction system? A. Hyperactive SA node firing. B. Sick sinus syndrome. C. Severe AV node block. D. Bundle of his automaticity. Answer: C. Severe AV node block. Rationale: in A-Fib, the AV node receives rapid, chaotic impulses from the atria. If the AV node is severely diseased or blocked, it conducts only minimal impulses, leading to a slow ventricular response, severe AV node block, which is known as A-Fib with a slow ventricular rate. Question 26. The nurse observes a pacemaker spike that falls directly onto the apex of the T wave of the preceding beat. This malfunction creates a high risk for which life-threatening dysrhythmia? A. Atrial flutter. B. Asystole. C. Ventricular fibrillation V-Fib. D. Supraventricular tachycardia SVT. Answer: C. Ventricular fibrillation V-Fib. Rationale: a stimulus, like a pacemaker spike, delivered during the vulnerable period of repolarization, the R-on-T phenomenon, which is the apex or peak of the T wave, can induce immediate ventricular fibrillation V-Fib. This specific pacemaker issue is often due to a failure to sense. Question 27. A patient's ECG shows a regular, slow rhythm, 42 beats per minute. There are no P waves, and the QRS complexes are wide, 0.14 seconds. The patient is symptomatic with confusion. The nurse should prepare to administer A. Lidocaine. B. Adenosine. C. Atropine. D. Metoprolol. Answer: C. Atropine. Rationale: the rhythm is likely an idioventricular rhythm or severe bradycardia of an unknown type, causing symptoms of low cardiac output confusion. Atropine is the first-line drug for symptomatic bradycardia, slow heart rates, to block vagal tone and attempt to increase the heart rate. Lidocaine A is for V-Tach, adenosine B is for SVT, metoprolol D would slow the heart. Question 28. A nurse is measuring the PR interval on a fast heart rate. The calipers indicate a measurement of 0.08 seconds. What does this finding most specifically suggest about the conduction system? A. Severe delay in AV node conduction. B. Conduction originating above the AV node, but utilizing a bypass tract, for example WPW. C. Conduction originating from the bundle of his. D. Delayed conduction through the bundle branches. Answer: B. Conduction originating above the AV node, but utilizing a bypass tract, for example WPW. Rationale: a short PR interval, less than 0.12 seconds, indicates that the atrial impulse is reaching the ventricle very quickly. This most commonly occurs with pre-excitation syndromes like Wolff-Parkinson-White (WPW), where the impulse bypasses the slow AV node via an accessory pathway. Question 29. A patient is in an undetermined wide complex tachycardia. Rate 180 beats per minute. The nurse is unsure if it is V-Tach or SVT with aberrancy. Which ECG characteristic is the most reliable sign pointing toward ventricular tachycardia, V-Tach? A. Presence of an inverted P wave. B. Presence of fusion or capture beats. C. Heart rate greater than 150 beats per minute. D. QRS with greater than 0.12 seconds. Answer. B. Presence of fusion or capture beats. Rationale. Fusion beats, a mixture of sinus and ventricular depolarization, or capture beats, a brief, normal sinus beat occurring during V-Tach, confirm that the atria and ventricles are depolarizing independently. AV dissociation, which is the most reliable single sign of V-Tach. Wide QRS complexes D can occur in both V-Tach and SVT with aberrancy. Question 30. A patient has an implantable cardioverter defibrillator, ICD. The nurse notes a rhythm of V-Tach, 155 beats per minute, and then observes a sudden, brief artifact followed by normal sinus rhythm. What event most likely occurred? A. The ICD delivered synchronized cardioversion. B. The patient performed an effective vagal maneuver. C. The ICD delivered a high-energy defibrillation shock. D. The V-Tach spontaneously converted to NSR. Answer. C. The ICD delivered a high-energy defibrillation shock. Rationale. A sudden brief artifact often represents the ICD device delivering a high-energy defibrillation shock, C, to terminate the life-threatening ventricular rhythm. ICDs often shock V-Tach. Cardioversion, A, is typically synchronized but uses lower energy. Question 31. A rhythm strip shows a ventricular rate of 150 beats per minute, a narrow QRS complex, and P waves that are regular and sawtoothed, with 2 flutter waves for every 1 QRS complex. This is a 2:1 block of which rhythm? A. Sinus tachycardia. B. Atrial fibrillation. C. Atrial flutter. D. Ventricular tachycardia. Answer. C. Atrial flutter. Rationale. The presence of regular sawtoothed P waves, flutter waves, is pathognomonic for atrial flutter. When the ventricular rate is exactly half the atrial rate, it's a fixed 2:1 block. For example, atrial rate 300, ventricular rate 150. Question 32. The nurse sees a short period of asystole followed by the appearance of a single, slow, wide, bizarre QRS complex before the original rhythm resumes. This complex is called A. Premature ventricular contraction PVC. B. Fusion beat. C. Compensatory pause. D. Ventricular escape beat. Answer. D. Ventricular escape beat. Rationale. An escape beat occurs when the heart's primary pacemakers fail, causing the asystole. A ventricular escape beat originates in the ventricles and is a protective mechanism. It is wide, slow, and occurs after a long pause, contrasting with a PVC, A, which occurs early. Question 33. A patient's ECG shows regular electrical activity, but the patient has no palpable pulse. The rhythm shows narrow QRS complexes at a rate of 70 beats per minute. What is the interpretation and clinical state? A. Asystole. B. Pulseless electrical activity, PEA. C. Ventricular fibrillation. D. Pulseless ventricular tachycardia. Answer. B. Pulseless electrical activity, PEA. Rationale. PEA is defined as an organized electrical rhythm, often narrow QRS at a near normal rate. 70 beats per minute is considered organized on the monitor, but the patient has no detectable pulse. This indicates a mechanical or volume failure despite electrical activity. Question 34. A patient with chronic heart failure has a telemetry rhythm that is sinus bradycardia, 48 beats per minute. The nurse notes a history of prescribed digitalis and a serum potassium level of 3.0 milliequivalent per liter. What is the most likely primary cause of the bradycardia? A. Digitalis toxicity potentiated by hypokalemia. B. Vagal stimulation from heart failure. C. SA node failure unrelated to medications. D. Hypokalemia directly causing bradycardia. Answer. A. Digitalis toxicity potentiated by hypokalemia. Rationale. While hypokalemia, 3.0 milliequivalent per liter, can cause ventricular irritability, PVCs, it also potentiates, increases the effect of digoxin, leading to signs of toxicity, such as bradycardia and various heart blocks. This combined effect is the most likely and complex cause. Question 35. When differentiating between an aberrant abnormal SVT and V-Tach, the presence of an RS interval, start of R to deepest part of S wave, of greater than 100 milliseconds in a chest lead suggests A. Supraventricular origin. B. Ventricular origin V-Tach. C. Atrial flutter. D. Pacemaker malfunction. Answer. B. Ventricular origin V-Tach. Rationale. The RS interval, from the beginning of the R wave to the nadir, or deepest point, of the S wave, exceeding 100 milliseconds, 0.10 seconds, in a chest lead is one of the classic Brugada criteria, a highly reliable ECG sign used to distinguish a wide complex tachycardia as originating from the ventricles, V-Tach. Question 36. The nurse sees two different pacemaker spikes, one followed by AP wave and a second followed by a QRS complex. This indicates the patient has which type of pacing? A. VVI pacing, ventricular sensed, ventricular paced. B. AI pacing, atrial sensed, atrial paced. C. VOO pacing asynchronous, ventricular only. D. DDD pacing, dual chamber sensing and pacing. Answer. D. DDD pacing, dual chamber sensing and pacing. Rationale. The presence of two distinct spikes, one for the atrium, one for the ventricle, indicates dual chamber pacing DDD, where both the atrium and ventricle are being electrically stimulated, paced, by the device. Question 37. A patient's rhythm is regular with a rate of 70 beats per minute. The QRS is narrow. P waves are present, but are inverted in leads 2, 3, and AVF. What is the pacemaker site? ASA node. B. High atrium. C. Lower atrium or upper junction. D. Ventricle. Answer. C. Lower atrium or upper junction. Rationale. The standard vector of atrial depolarization is downward and left, causing positive P waves in leads 2, 3, and AVF. Inverted P waves in these inferior leads indicate retrograde atrial depolarization. The impulse is traveling upward, suggesting the origin is near the bottom of the atria or in the AV junction, lower atrium or upper junction. Question 38. The nurse observes a patient's rhythm alternating between runs of sinus tachycardia, 115 beats per minute, and episodes of sinus bradycardia, 45 beats per minute. This pattern is most commonly associated with which chronic condition? A. Ventricular aneurysm. B. Brugada syndrome. C. Sick sinus syndrome, SSS. D. Chronic atrial fibrillation. Answer. C. Sick sinus syndrome, SSS. Rationale. Sick sinus syndrome, SSS, often termed tachybrady syndrome, is a complex disorder of the SA node characterized by alternating periods of slow rhythms, bradycardia, sinus arrest, and fast rhythms, tachycardia, atrial flutter or fib. Question 39. When assessing a patient's ECG for signs of cardiac ischemia, which finding is the most specific for an acute transmural full-thickness injury? A. T-wave inversion. B. Elevated ST segment. C. Depressed ST segment. D. Prominent U-wave. Answer: B. Elevated ST segment. Rationale: ST segment elevation STEMI is the hallmark sign of an acute transmural injury or infarction to the myocardium, indicating a current of injury that requires immediate intervention. T-wave inversion A and ST depression C typically indicate ischemia or non-transmural injury. Question 40. A patient is in second-degree AV block, type 2. The nurse recognizes that this rhythm is particularly dangerous because it often progresses rapidly to A. Sinus tachycardia. B. Atrial fibrillation. C. Third-degree AV block, complete heart block. D. Supraventricular tachycardia, SVT. Answer: C. Third-degree AV block, complete heart block. Rationale: unlike type 1 Wenckebach, second-degree AV block, type 2, is typically due to a block below the AV node. Because the site of the block is less stable, this rhythm carries a high and rapid risk of progressing to third-degree AV block, complete heart block, which necessitates pacing. If you found this video helpful, don't forget to like, subscribe, and share with your fellow nursing students. Hit the bell icon so you never miss an update. See you in the next one. Happy studying.